Hello and welcome back to the Gluten Free RN podcast. I'm Nadine, the Gluten Free RN. Today, during episode 69, I am going to talk about eosinophilic esophagitis and celiac disease. Is there a connection? Stay tuned to find out. Hello and welcome back to the Gluten Free RN podcast. I'm Nadine, the Gluten Free RN. Today, during episode 69, I am going to do a little bit of a talk on eosinophilic esophagitis, which is hard to say, it's a little bit of a tongue twister, and celiac disease. Is there a connection? Well, interestingly enough, there might be, but the research is still out as far as the connection. Is it just a coincidence when celiac disease and eosinophilic esophagitis show up together, or is it causal? We don't know the answer to that yet, believe it or not. There are dozens and dozens and actually thousands of references to eosinophilic esophagitis and celiac disease on Google, but the research is not very conclusive at this point. There's a lot of theories, there's many ideas about the crossover, but there is no real definitive, yes, celiac disease and eosinophilic esophagitis are connected, but we're going to talk about that a little bit today. Ooh, what exactly is eosinophilic esophagitis? How do you spell that? Is there a short way to actually talk about that? So sometimes eosinophilic esophagitis is referred to as EE or EOE in the literature. And if you're looking it up and you're tired of saying eosinophilic esophagitis or you just can't say it, you can always refer to it as EE or EOE. And interestingly enough, EOE actually started to be recognized over the last 2 decades. And before that, I'm not quite sure if it was referred as something else or if it really just showed up in patients in the last 2 decades, which is interesting. So basically what EE is an inflammation of the esophagus, which leads to increased eosinophils in the blood. So it's an abnormal reaction or a response to dietary antigens with elevated eosinophils. Now, we would notice that there are increased eosinophils when a blood draw occurs that involves a CBC or a complete blood count with a differential. The differential would be the part of the blood draw or the blood results that actually shows all of the different white cells in the blood. So eosinophils are part of that mast cells. So the differential part of the complete blood count would include things like neutrophils, monocytes, eosinophils, and depending on which lab is doing it, it may include a few others. But for the purpose of this talk, we're going to talk about the eosinophilic portion of that blood test. So if the eosinophils are elevated, it could be an indicator of some type of increased immune response that is triggering your eosinophils to react. I became interested in this for a number of reasons. One, I have a lovely client who has EE and also has to be on a special diet. We looked at him very closely for having celiac disease, and I'm waiting for his parents to call me back to find out if he actually was diagnosed with celiac disease or just EE. There is a fair amount of crossover sometimes in the symptomology of EE and celiac disease. And as I've said, there's lots of research and there's lots of actually case studies reported, but the jury is still out as to whether it's a causal effect and not just overlap. There are a few studies that have shown a significant correlation between celiac disease and eosinophilic esophagitis. I spent the morning doing quite a bit of research and reading quite a bit. And honestly, I didn't learn a lot more about eosinophilic esophagitis and celiac disease, but there are some really fascinating new things that I did actually come across. I looked up Children's Hospital in Colorado because I know that there had been several studies on eosinophilic esophagitis and celiac disease. Until recently, this article says, they had to perform an upper GI endoscopy with biopsies for a child with eosinophilic esophagitis, which required deep sedation or general anesthesia and a 4-hour stay in the hospital. So what they ended up doing is this really cool procedure in which they pioneered a new way to monitor the treatment in EE, which is called a pediatric transnasal endoscopy with biopsies, or referred to as a TNE. So apparently it had been used in adults to monitor Barrett's esophagus, but no one had yet studied it for EE or in young children. Furthermore, the endoscopy used for unsedated transnasal endoscopy in adults was 4.9 millimeters in diameter, too big for most children. But apparently they have a different tube that they can use, and it's between 2.8 and 4 millimeters in diameter, which they use for pediatric bronchoscopy or flexible laryngoscopy. So they wondered if that tube could work, and apparently it does. And the interesting thing is it takes 1 hour average time from admit to discharge compared to 4 hours with sedation endoscopy. It's a third of the cost of sedated endoscopy. And it's only 2 hours without eating instead of 10 hours with general anesthesia. So you can begin to see why it would be ideal not just for children, but for most adults too, especially since it's cheaper and you don't have to go under general anesthesia. And it takes place in an outpatient exam room. Very simple procedure, a little bit of numbing medication that's topical, and they get the same information. So quite ideal. So that's one new thing I learned, and quite cool, by the way. So transnasal endoscopy. I'd like to ask about that the next time if I have to go in for an endoscopy. I'd much prefer that procedure. So what is EE? Once again, is an abnormal allergic response to dietary antigens with elevated eosinophils. What would be the symptoms of that? Some of the signs and symptoms would be vomiting, difficulty swallowing or dysphagia, food that gets stuck in the throat, and sometimes that needs to lead to an esophageal dilation. The symptoms can also include chest pain, persistent heartburn, upper abdominal pain, and no response to GERD medications. So let's review the fact that the GI tract is 30 feet long, starts in your mouth. You have your throat, your esophagus, your stomach, the duodenal bulb, the duodenum, the jejunum, ileum, colon, rectum, and anus. So all of that, stretch it out. It's about 30 feet long, and your esophagus is definitely a part of that 30-foot long tube. So we know that celiac disease affects the mouth all the way to the rectum, and it can be anywhere in between, and it certainly is systemic for many people. Some people don't have any symptoms, so one of the reasons I find celiac disease so fascinating is the fact that people present with so many different symptoms, but the common denominator for a lot of my patients is that they have undiagnosed celiac disease, or they have diagnosed celiac disease and we just have to work to get them better. So it is noted that mostly children have EE or eosinophilic esophagitis. And what those symptoms that I just mentioned, the vomiting, difficulty swallowing, food stuck in the throat, failure to thrive, malnutrition because you can't get nutrients because you can't eat. There is a lot of overlap with celiac disease and those presenting symptoms. There's also another interesting GI issue, and it's called achalasia. And that's when the muscles of the esophagus aren't working appropriately and either spasm or they cause a constricture in the esophagus, also leading to a potential dilation of the esophagus or surgery to correct it. Sometimes medications work and sometimes they don't. But interestingly enough, it would be another great study to do to find out if there was a correlation between achalasia and celiac disease. Couldn't find out very much information on that, but it would be another fascinating study. Another one of the common overlaps is because it's an immune reaction to food that kids are eating and sometimes adults, one of the primary treatments is to remove 6 foods from the diet. And those 6 foods include wheat, eggs, milk, shellfish and seafood, peanuts and tree nuts, and soy. So those are the primary things that are included in the elimination diet for EE. And what most of the practitioners find is that the kids overwhelmingly improve. So I would include gluten along with wheat, which would include the barley and the rye, to optimize the potential for these kids to get better on a elimination type diet as a treatment for EE. Otherwise, some common treatments would be topical steroids, which are typically inhaled, the elimination diets, and then systemic steroids, which of course everyone tries to avoid in children for a number of reasons, mostly because they're growing children and we don't want to suppress their immune system any more than it already is. We want them to grow because the steroids will impact bone health. But if a child needs to be on a steroid or some type of medication, of course, always follow what the primary care provider and the specialist are recommending. But a diet change or an elimination diet does not really have any downside. There's no risk to doing an elimination diet, provided that all of the nutrients are accounted for and supplemented for. I have included a fair number of research articles on eosinophilic esophagitis in the podcast notes, so you can refer to those if you're really interested in this topic. There are quite a few really interesting reads. I'm going to reference this one, Eosinophilic Esophagitis Associated with Celiac Disease in Children. And this one is authored by Dharmaja, Haglund, and Lyons, and was in BMC Research Notes as a research article. And this particular article was published in 2015. And I'll just go ahead and read the abstract, or at least most of it. The background is the celiac disease and eosinophilic esophagitis are distinct diseases of the gastrointestinal tract with specific clinico-pathological characteristics. Recent studies have found higher rates of EOE in patients with celiac disease than in the general population. Our aim was to estimate the incidence of EOE among children who were diagnosed with celiac disease over a 42-month period. The methods were the study included patients diagnosed with celiac disease based on endoscopy and histopathological findings between January 2010 and June 2013. Histopathologic reports of esophageal biopsies were reviewed to identify all cases of EOE. The patients presenting symptoms, laboratory evaluations, endoscope and histopathological findings, treatments, and follow-ups were analyzed. 56 patients with celiac disease were identified, of whom 6, 10.7%, were diagnosed with both CD and EOE, eosinophilic esophagitis. Four of these patients presented with abdominal pain and diarrhea, 2 presented with failure to thrive, and 3 presented with food allergies. Endoscope and histopathological changes typical of EOE were observed in all 6 patients. During follow-up, 2 patients showed significant improvement with the gluten-free diet and a proton pump inhibitor, or PPI. 2 patients improved with the elimination diet, and 2 patients were treated with topical corticosteroid therapy. Endoscope appearance was normal in all children on follow-up endoscopy after treatment. Biopsy samples also showed resolution of the histological features of EOE in all of the children. Conclusion: the incidence of EOE in our cohort of children with celiac disease was 10.7%, which is higher than what has been reported for the general population. In all children undergoing upper gastrointestinal endoscopy for suspected celiac disease, coexistence of EOE should be considered. So there's a great article with a terrific abstract. If you want to take that in for any child that is having difficulty with food or allergies. And this particular study did in fact show that there was a higher incidence of celiac disease and eosinophilic esophagitis coexisting together. There are several articles in which they show that it does not coexist together, that celiac disease and EOE are separate entities, and typically people do not have them together, or children do not exhibit them together, which is interesting. But is EOE, which is an inflammation and a food allergy and an immunological response to food? So it's an immunological response to food in which your immune system goes, hey, we don't like this, or it's an inflammatory food, which once it's removed, actually causes the EE to resolve. And that's probably a good thing considering what the symptoms are. Vomiting, difficulty swallowing, chest pain. Nobody wants to have those symptoms, especially children. I'm also going to read a case report, which is Eosinophilic Gastrointestinal Disorder and Celiac Disease, a case report and review. And just as a reminder, you can refer back to the podcast notes. I have included everything, and there's several research articles and case reports that are included in the podcast notes for this episode. This is Case Reports in Gastrointestinal Medicine, Volume 2012, and this is a paper penned by Lim, Wilkins, Horton, Ahmad, Pulido, and Phillips. And it does come from the UK. It is dated November 2012, just so you can find it in the podcast notes. This is the introduction. Eosinophilic gastrointestinal disorder is an unusual inflammatory gastrointestinal disease characterized by eosinophilic gut infiltration. There have been case reports and cohort studies suggesting an association between eosinophilic esophagitis and celiac disease in children. However, there are no previous reports or studies to indicate an association between celiac disease and eosinophilic gastrointestinal disorder in adults. This paper examines a patient with concurrent eosinophilic gastrointestinal disorder and celiac disease. So I'm just going to read the first part of the case report, which says it's a 30-year-old Caucasian female who presented with a 2-week history of central abdominal pain and distension, vomiting, and increased frequency of bowel motion. There had been no weight loss or history of foreign travel. She was known to have celiac disease diagnosed at age 2. She was compliant to gluten-free diet. There was no history of drug allergy, asthma, or skin eczema. Abdominal examination showed signs of ascites. There were no stigmata of chronic liver disease. The rest of the systemic examination was also within normal limits. A summary of her laboratory investigation is presented in Table 1. She had a CT of the abdomen and pelvis, which showed large volume ascites and prominent small bowel loops. There was no evidence of a pelvic or peritoneal mass. A diagnostic paracentesis showed straw-colored ascites, and they did colonoscopy and biopsies of colonic and terminal ileal mucosa, which were normal. Histological examination of duodenal mucosa revealed Marsh 3 villus atrophy consistent with celiac disease, although no previous biopsies were available for comparison. Jejunal mucosa showed dense infiltration of eosinophils on the lamina propria. There was no histological evidence of an enteropathy-associated T-cell lymphoma, granuloma, or malignancy. Unfortunately, the endoscopist did not obtain esophageal and gastric biopsies. So here we have a lady who was diagnosed with celiac disease at age 2. She presents as a 30-year-old with ascites, and she has really significant health issues because apparently she's not really on a gluten-free diet, but she does not have refractory celiac disease at this point. So somewhere she's getting gluten. And for this lady's treatment, she was started on IV hydrocortisone 4 times a day with rapid resolution of her symptoms and eosinophilia. However, the length of steroid treatment was greatly influenced by the development of steroid-induced psychosis. Her psychosis had resolved upon discontinuation of steroid and did not require a long-term antipsychotic treatment. So the steroids are not without risk. Just do keep that in mind. But if you need them, that would be up to you and your doctor to discuss. So you really do have to review all the risks and benefits of any medication that you're potentially going to take. So this patient had elevated eosinophils in blood in different tissues that have been found in celiac disease. The coexistence of eosinophilic gastrointestinal disorder and celiac disease in an adult should be considered when a patient presents with ascites in the absence of liver disease and unexplained gastrointestinal symptoms. So while this is not actually eosinophilic esophagitis specifically, it is a lady that does have an increased response of her immune system with eosinophils. So really just something to keep in mind, especially if you're a practitioner or if you have elevated eosinophils yourself or a family member has elevated eosinophils. It's a good idea to keep all of this in mind, or at least have an idea that they can coexist. And that if eosinophilic esophagitis is treated with an elimination diet, at least as a primary treatment plan, as is celiac disease, then maybe there is some overlap that has not been investigated correctly yet, or maybe it needs to be looked at in a slightly different way than has been done in the past. By the way, my eosinophils have been consistently high. I myself have elevated eosinophils every time I have a CBC with a differential drawn. I do note that. It's an interesting finding, but I'm not quite sure what it means for me. I'm fairly certain I do not have eosinophilic esophagitis. And there's so many things I've already eliminated, certainly all of the top foods that would be eliminated for a person with EE anyway. Maybe I am treating it. And strictly with diet, by the way. There are some specialty clinics in the United States that treat eosinophilic esophagitis in children and adults. One is the University of Colorado Denver School of Medicine. And I know there's several programs also in Pennsylvania that are really good at researching and studying and seeing patients with eosinophilic esophagitis. There is one doctor that keeps coming up. His name is Glenn Ferruda, and there is an article that says Advances in GERD. And this particular article was published in Gastroenterology and Hepatology, Volume 4, Issue 11, November 2008. And this is entitled Eosinophilic Esophagitis in Children and Adults on our topic. And it's basically just an interview with Dr. Ferruda. And one of the questions posed to Dr. Ferruda is eosinophilic esophagitis more prevalent in children than adults? And basically what he says is that recently studies in adults have reemerged, emphasizing the importance of this disease. Thus, we do not yet have long-term studies on the exact incidence, prevalence, or natural history of the disease in either of these patient populations. The next question is, could you explain the difficulties of confirming a diagnosis of eosinophilic esophagitis in patients? The answer he gives is, since eosinophilic esophagitis is a relatively new disease with only recently identified diagnostic guidelines, clinicians must rely on both clinical and histological data to make the proper diagnosis of eosinophilic esophagitis. Currently, there is a growing tendency to merely read a pathology report and automatically make a diagnosis of eosinophilic esophagitis based upon this single finding. An increasing body of data supports the fact that large numbers of eosinophils can be found in a variety of diseases, including GERD, eosinophilic esophagitis, inflammatory bowel diseases, and celiac disease. Previous work and clinical experience in children suggests that the majority of children with esophagitis characterized by increased eosinophils have reflux, not eosinophilic esophagitis as the etiology. Thus, prior to making the diagnosis of eosinophilic esophagitis, a thorough examination of the clinical features of the patient must be performed to rule out any other causes. The distinction between reflux and eosinophilic esophagitis is particularly important because of the treatment and long-term outcomes of the disease are so divergent. So again, it is mentioned that instead of just diagnosing eosinophilic esophagitis based on the biopsy of the esophagus, that all practitioners need to keep in mind that potentially there is overlap with other diseases, including celiac disease and inflammatory bowel diseases, which I always have to say, hey, what's inflaming the bowels? And typically it's what we're eating. And this is what I found very interesting and quite compelling to keep in mind, especially for practitioners. The question was, are there any special concerns when treating pediatric patients with eosinophilic esophagitis as opposed to adults? And the answer is there are several special concerns for treating pediatric patients that relate to the overall goal of promoting their normal growth and development. First, since nutritional management may include an elimination of single, multiple, or all food products, one of the cornerstones of treatment is consultation with a pediatric dietitian. The expertise of the dietitian is required to ensure that the child's diet includes an appropriate number of calories, protein, fat, carbohydrates, and micronutrients. Second, attempts should be made to limit the exposure to corticosteroids because of their known biochemical impacts on bones, growth, and cataract formation. The third concern relates to the initial assessment and attention to the development of feeding skills. Young children enter an important stage of oral development, often at the same time that they develop eosinophilic esophagitis. As such, normal oropharyngeal development may be impaired and milestones may not be reached. Due to inflammation, eating is often associated with pain, which may discourage children from eating. Even if the child's inflammation is brought under control, there may be continued learned avoidance behaviors that may last for months and require special attention. Finally, children may develop psychosocial or behavioral problems associated with the disease or treatment. Eating is clearly an important social and emotional component of daily life. When this component is disrupted, family, school, and social functions are impacted to a significant degree. Well, certainly those of us with celiac disease know how social functions can be disrupted or different if you have to be on a gluten-free diet. So here we have a situation where children have to be avoiding or eliminating from their diet very specific foods. Interestingly, I found one of the websites actually included the foods to avoid, but then also said that children could continue to drink sodas and energy drinks and all these foods that I would consider not to be foods or to be super high in sugar. And I also found references to the fact that eosinophilic esophagitis could be related to a candida or a yeast overgrowth and triggered by that. So that involves a whole dysbiosis or small intestinal bacterial overgrowth or a disruption of the microbiome. And all of these things, to my knowledge, have not been evaluated appropriately. And if they are in the literature and you do find them, please send me those research articles. I would love to learn more. So there you have it, a review of eosinophilic esophagitis and celiac disease. Is there an overlap? We'll all have to stay tuned to find out the answer to that. Or is eosinophilic esophagitis just a manifestation of celiac disease in the esophagus? These are all interesting questions, all of which need to be answered over the next few years. And if you have a child that has eosinophilic esophagitis and celiac disease, or just EE, please let me know what you do and what you find is the best treatment for your child, or for yourself if you're an adult with EE. As we're discovering, more and more adults are developing eosinophilic esophagitis. Interesting how the standard American diet or the Western diet is potentially causing many of these issues with our gastrointestinal tracts. This is such a great reason to focus on whole foods and a paleo type diet where we're removing all of the, as I like to say, subsidized foods or the foods that are typically found in allergic reactions, whether it's an IgE, IgA, IgG, IgM mediated antibody response. You really do need to start to look at the underlying cause of whatever these inflammation type diseases are or inflammatory conditions. This has been episode 69 of the Gluten Free RN podcast, in which we reviewed a possible connection between eosinophilic esophagitis and celiac disease. I hope you found this information really important, or at least thought-provoking. And if you've enjoyed this episode or any other episode of the Gluten Free RN podcast, please leave a rating or a review, or both, on iTunes, Stitcher, or wherever you listen to this particular podcast, the Gluten Free RN. I'm Nadine Gruskowiak, the Gluten Free RN, and I'm going to sign out of episode 69. For now, stay tuned for the next episode, where I think we're going to talk about blood dyscrasias, which means any impact that celiac disease can have on your blood. Stay tuned. Bye.